Okay, good morning, everyone. Thank you so much for having us here today. My name is Kara, and we are Team Penn State. So NittanyNav is a resource recommender to help patients and social workers navigate the barriers to access in the healthcare system. Now, you might be getting a little bit of deja vu, since this is actually a similar concept to Dr. Lindau's Community RX and NowPal, and we wanted to take it one step further and add AI to help with a specific focus on social workers. So when approaching this project, we decided to take a step back and look at the big picture, which included examining social determinants of health. Social determinants of health encompasses social economic status, neighborhood and physical environment, food environment, healthcare, and social context. Inequalities in social determinants of health can lead to healthcare disparities. For example, not all patients have access to the means to access nutritious food, which can lead to poorer health and subsequent continuing widening of healthcare disparities. An area that we felt that we could meaningfully address was access to existing resources and connecting social workers and patients to resources that best fit their needs. Now, this is an area in which social workers are particularly adept, but they often face challenges such as worker shortage, burnout, and lack of resources. Social workers have a lifetime burnout rate of up to 75%, and over 50% of social workers felt overloaded with caseloads and work. There's a predicted shortage of 200,000 social workers by 2030. This all can lead to less time spent with each individual patient, missed work, poor work errors from burnout, which can be detrimental to patient care. One of the biggest returns on investment for preventing burnout in social workers includes prioritizing resources available within an organization, adequate staffing, and time needed to accomplish tasks. Our product would help aid and augment social workers in their day-to-day lives by providing them with tools so they can be more efficient and personalized with their patients and caseloads. Currently, AI is used in healthcare in a variety of ways, including some of the examples you see pictured here on the slide, but none of these specifically focuses on addressing the underlying complexities contributing to healthcare disparities. Oftentimes with technological advancements, there are barriers patients with social determinants of health might face, such as having access to smartphones, electronic devices, or even to the healthcare system itself. This is where we come in. We want to promote health equity with our project, meaning equal opportunity and access to available and up-to-date community resources. Our goal is to utilize AI to help social workers who are inundated with patients with unique needs and mountains of resources to go through. This new approach is what made this project particularly challenging and rewarding. This project presented us with challenges such as gathering demographic data and social determinants of health data, which are not as readily accessible or quantifiable as some like off-the-shelf use cases, such as things like medical imaging. But we believe this work is worth the effort and the product has the ability to make a meaningful difference. So just as a reminder, our goals for this project is to create a personalized recommender system for community resources. And through this, we wanted to be able to mitigate social determinants of health, improve access to community resources for social workers and patients, and ultimately improve health outcomes through this increased resource accessibility. So now tackling all social determinants of health for all patients is a pretty lofty goal. Therefore, we chose to narrow our scope for our initial model development and proof of concept. We chose to target a target population of diabetic patients, since this is widely prevalent at 11.3% in the nation, costs an estimated $327 billion per year, and diabetes almost has double the prevalence in lower income patients. Research has shown that fewer local resources correlate with high BMI, which negatively impacts disease. Therefore, the first resource we chose for our model development was food insecurity. So on this slide, we have outlined what we've been up to for the last few months. We went through an extensive data collection process, including IRB approval, sourcing data from TriNetX and Penn State's own EMR. Then we worked on developing the machine learning framework and the training system. This leads us up to now with our proof of concept and interface prototype. Now I will turn it over to Hyatt to go into a bit more detail about our development process.
Hello, everyone. The statistics you see outline the characteristics of TriNetX data we requested to ultimately build our AI algorithm. The uniqueness of our solution is a result of having real-world, diverse, accessible data with high quality. So to explain how food insecurity is determined within our EHR data, we looked for type 2 diabetes patients who are also diagnosed with potential health hazards related to socioeconomic and psychological circumstances. And we found that around 140 patients have problems related to housing and economic circumstances in which food insecurity is found. To develop our algorithm, we aggregated two data sets: the patient's data and the target locations data, which are food providers like food banks, churches, and many others. We started with a simple list of locations in central PA we obtained from scraping the internet using web mining techniques. Looking at the development flowchart, we can break the system's algorithm development into two phases. First is the warm-up phase, where we used clustering methods to assign similar patients to a target location based on the shortest distance. We used this distance as a score or a rating for our target, since the system is built from scratch without prior knowledge about the patients or the user's satisfaction. The second phase is the training of the recommender system algorithm with 80% of the patient's data, then using the rest 20% to test the algorithm, which predicts the target locations. The score matrix here illustrates an example output we got running our algorithm with dummy or synthetic data generated from a Python library called Faker. As mentioned in the previous slide, this matrix calculates initial ratings by finding the shortest distance between each patient to the list of all locations in our database. Although kept out of scope for now, the success of our system is measured using various performance measures. On the academic side, we aim to minimize the root mean square error by working with high quality data, always enhancing model complexity and tuning our hyperparameters. Later on, to test the system's usability, surveys or interviews can be conducted with social workers to enhance the user's experience. And now I hand it to Sheikha to talk more about the interface.
So our current model currently processes the input from the social worker to provide a recommendation. It chooses the zip code, insurance, birthday, gender, type of disease. Currently, our model focuses on diabetes. And what resource are they looking for? We're currently focusing on food disparities. The model then provides a list of the most appropriate choices for the case. To keep improving recommendations provided to the patients, we allow the user to review the recommendation choice. The scheme allows the developers to update the scoring matrix of our recommendation system. The application also provides a Patients Like Me feature, which provides choices that worked for similar patients suffering from the same disparity, using the clustering feature or the KNN algorithm and implementation. Finally, the application has an introduction page for more information about what it does, and a support tab to allow adding new resources that was not included originally, or to report a bug in the code. It also provides a button for email communication with the NittanyNav.
So during the development of our prototype, one of the main challenges we had was our data set, particularly the fact that we used a synthetic data set. We had obvious limitations. For one, we didn't have the features that we necessarily might need to make meaningful recommendations. And two, we weren't able to quite deploy this in the real world, so we don't have that kind of real world feedback or analysis of its performance. Despite these limitations, however, we have shown you a proof of concept that this can in fact work to tackle social determinants of health as it relates to diabetes. And importantly, these challenges are easily addressed. Moving forward, there are a few approaches that we will take to address these challenges. For one, we'll expand our data set using real patient data, increasing our user base, and incorporating more of these patient variables to identify variables that matter and can provide useful recommendations. Two, we'll continue refining our algorithm. We'll do this by incorporating user feedback and enlisting new resources as they come. And I think this is where our product really shines, that it's able to evolve with the community as engagement changes. And lastly, we'll kind of polish the experience of NittanyNav. We'll work on our user interface and discuss with social workers to improve its usability and performance. Considering all of this, we believe we have a very attractive and marketable product. For one, it's easily integratable. There aren't very high barriers in getting this to work. We're not requiring any expensive software or hardware. It doesn't even rely on patients to learn or download a new application. Instead, this is really driven by the social worker. And as we've mentioned, this is easily adaptable or adaptable with the community as things change. Additionally, there is room for this to expand. We're building this based on food insecurities as it relates to diabetes, but it can expand into other social determinants of health and any other disease. And although there are similar products that we've seen so far, this is unique in that it is able to utilize AI to recommend resources, and in our case, specifically food insecurities in the setting of diabetes. So what's the overall take-home message here? Why should we care about NittanyNav? So in the spirit of the competition, we're creating a product that capitalizes on growing AI technology to address health disparities. We do this primarily by connecting patient to community resources. As we've seen, we do this with efficiency, being able to sort through hundreds of resources and connecting it with the complex variables that define patients. And with discussion with social work, this alone is an exciting feature for them. And these recommendations are all personalized because of this. This is similar to what patients are familiar with Amazon, being able to promote products that somehow they know they need, or Netflix being able to show that of course they'll love. But the main draw here is that we are able to improve health outcomes. Studies have shown that by addressing social determinants of health, we can decrease A1C, an important marker in diabetes, and we can expect similar improvements in other areas such as health, cardiovascular complications, and also reliance on complicated or costly medications. So with all this, we have no doubt that with continued development, NittanyNav will be an extraordinary asset in the healthcare setting, and it will do so by leveraging AI to alleviate health disparities. So thank you all for lending your attention and hearing about our product, NittanyNav. We hope that you're as excited as we are about seeing this come to life. And we also want to give special thanks to Carson Hanna, who is a social worker we consulted for the project, and Dr. Kelly Shields, who is our advisor for this program. And on the next slide, you'll see everyone that made our wonderful team that could make all this happen. And with that, we'll take any questions you guys may have.
Hello, this is Sheila.
So it looks like our first question.
Oh, great. Shawnee, is it possible that I could just go ahead and make a an appointment for 3 weeks from today?
Hold on.
I muted it.
Okay. Yeah. Selena, would you like to ask your first question?
Yes. Are you all familiar with community health workers? Okay, so community health workers is a broad umbrella term. There are about 900 professions under the banner of community health workers, but they essentially do like what you're wanting to do, minus the technology. So there are community health workers that work in a variety of settings. In the Hispanic communities, they're called promotoras. In the indigenous communities, they're called CHRs. We partner with the National Association of Community Health Workers. They're all over the country. And what they do is provide services to patients, and many big hospitals are actually creating their own community health worker trainings. So that way they can hire community health workers because they're known to have greater trust. And so I think at the heart of what you're trying to do, it makes sense. I would say look into community health workers because I think you'll have a larger force than just social workers. They're also trained differently in terms of some of them actually provide care. So they may have like diabetes screening, they may do blood pressure screening, they follow up with patients a little bit more and have a little bit more of a clinical kind of feel to them than I would say a social worker. So I would definitely look into them because I think they may be like a little bit of a better model for what you're trying to do. The other thing that I would say is I love the idea of using technology to find the resources to connect it to the patients. I think the other thing to think about is I was talking to a big academic institution. They have a hard time getting patients to sign up to their portal. So just think about like the ease of technology adoption. Actually, that academic institution is using community health workers to go into the community to educate them about the portal. But the technology barrier is a significant one. And the other thing that I would encourage people to think about, I think health equity is such a broad term, but sometimes we make health equity a problem for the poor. And I like to tell people I'm a very educated Black woman and I still face health disparities, not because I can't access care, but because of bias in the racial healthcare system. So I just invite you all to consider that in some of your framing and language around the problem in terms of who is this really for and how does it really solve health inequities, because it may impact health inequities for a very specific portion of people. But I think it's really important that we don't frame health inequities as just a poor people's problem, because the more I learn about community health workers, I actually think almost everybody should see a community health worker because they have more time than a doctor, a nurse. There's more of them. There are many benefits to adopting a community health worker model besides just income related. So I think it's something to disentangle because they're not necessarily the same. So just some thoughts to consider.
Oh, yeah, thank you for that. Yeah, certainly we weren't really, I guess our thought was any kind of need that we would be able to address, not necessarily income. But I guess I kind of do have a follow-up question about these community health workers. I guess where do patients usually interface with them? Like, is it usually in clinic or like
No, so
what's the
they work
typical
all
setting?
So there's community health workers in New Mexico that have like medical equipment in their car and they drive and help like homeless people. They're community health workers that work in hospitals. They're community health workers that work in community health centers. There are some, for example, Columbia University is training them and they just like walk around Harlem and like knock on people's doors. So they don't necessarily interact with traditional healthcare systems. There's a whole underbelly. So just look into like community health workers, community health centers. There's a lot of research in there. A lot of organizations have proven data about their impact on health disparities.
I think that's a great idea. Thank you for that information. And we'll definitely make sure to look into that and incorporate that into future models and developments of our product. So thank you so much.
I want to concur that this is great to hear that community health workers are also interested in the type of AI tools that we are developing, and we would be so thrilled to get inputs from this group of very, very important social support.
So I've got a couple of questions. So the first question is, how does this actually differentiate from something like Now Power Unite Us, given the discussion we just had? And I think you guys led with that. First question. Second piece is, we are a heavy user of Now Power. So we have 82% of our patients on our MyChart portal. We use Now Power. Patients actually get screened for social influencers of health, and then it delivers exactly in a very similar manner the materials. But the gaps actually end up being, now that you've delivered that material, actually getting patients to connect with those resources. So that's problem number one. And problem number two is whether or not the supply of resources actually exists at the end organization that you're connecting them with. Because there is a massive shortage of those social resources that are actually out there. So we may want to connect all of these patients to these resources, but that one resource may actually be tapped out. It doesn't have any more capacity to support that patient population. So how do you solve for those two as you're thinking?
Yeah, I think those are great questions. So there was a couple different questions in there. So I'll kind of focus on the last one that you had first. So one of the, so you said, yeah, we also recognize that problem, whereas like, yeah, we might be recommending a bunch of patients to the certain resources, but that's where we have our feedback button. So you can suggest new resources and then you can update like the availability of that resource. Like say like we would have features saying like, oh, like this is a new resource that you can use, or these are like the times that this resource is open, and like feedback on that. That would eventually be incorporated into the model. So that was kind of how we were planning on addressing that. And then also, so I guess how it kind of differs from NowPal, because we were talking about that. So we were looking at more of a focus on social workers, and then the great suggestion of focusing on community workers, like community health workers as well, because those people have more interaction and a more like personal interaction with people, rather than it being driven through healthcare providers like doctors and things like that. Because like you said, we can give people the information, they may or may not use it, is the other thing. So I think having like a more like focused set of people like the social workers or the community health workers, I think would help with that. Yeah, does anybody else from